Hi, this is Dr. Murdoch, moving on to part 2 of chapter 13, where we'll talk about small n designs. So the small n design, n refers to the number of participants, so small n, by definition, have relatively few participants, sometimes only one participant. In table 13.2, you can see some of the differences between large n and small n designs. Basically, in large n designs, we treat the participants as a group, so we don't take out data just from an individual participant to present. Everything is aggregated. We present the data as group averages. Whereas in the small n designs, each participant is treated separately, and we do present the data for each individual. So there are a lot of case studies in psychology, and likely you have heard many of these in previous classes. One of them that you are likely to have heard about is the research on Henry Molaison. He is often referred to as HM. We learned a lot about human memory from the case study on HM. He had epilepsy. He suffered from debilitating seizures. They reduced the quality of his life to the point where they did surgery to remove the front half of his hippocampus on both sides. And what happened to him following that surgery was so interesting that it became a topic to be studied for over 40 years with HM. So what happened was that he couldn't form new memories. So he could remember things from before the surgery, but he couldn't form new memories. So he was a very generous participant. They were able to study him for many decades and learned a lot about memory. For example, learning more about declarative and non-declarative memory. So in this picture here, you see the star tracing. So they taught him how to trace the star pattern with a pencil while seeing his hand only in a mirror. And so he got very quick at being able to do this over time. So it's a difficult task, but over time he could improve in that task just as quickly as that of a control participant who had an intact brain. But when he saw this task each day, so each day when he came in to do the task, he'd claim that he had never tried it before. So that's that declarative memory, knowing that you know that, versus the non-declarative, just knowing how. So he knew how to, but he didn't even realize that he knew how to do it. So a lot of great information was learned doing this case study on HM. And if we were in class, I would ask you at this point to tell me about some of the case studies that you've heard about before, because there are some very fascinating things that we have learned through case studies. Just as the quasi-experiments can take advantage of natural events in our world, small n studies often take advantage of special medical cases, so rare things that are happening that allow us to get a glimpse into something that maybe we don't have a lot of knowledge about already. And so HM, of course, was one of those cases where they could take advantage of a special medical outcome that had occurred and learn more about the topic of memory. But how convinced should we be by results on these special cases? After all, they're conducted with only a small number of participants. Well, the small n studies can effectively advance our knowledge when the researchers use careful research designs. So if they designed a sound methodology to be able to test different things, then we really can make some valid conclusions. So one of the things that the researchers with HM did was use the power of experimental control. In some cases, they compared Henry's ability to an age-matched control participant who had no brain damage. And they also deliberately designed tasks that were meant to isolate different elements of memory. So if they are taking great care to use sound methodology, then we really can learn valuable information. Obviously, there's some disadvantages to small n studies. There's the internal validity component. So are we really sure that it was the absence of that part of his brain that caused the changes? Or are there alternative explanations? For example, he had some damage from medications that he took for epilepsy. So there definitely can be a question of internal validity. There can also be the question of external validity. So if we only have one or a few people in this condition, would those same results apply to others? So in the case of HM, would the results from the studying that they did with him apply to people who do not have a history of epilepsy? So we can gain great information from these small n studies, but we do have to make sure that we understand the limitations of them as well. The experimental designs that are used in small n designs are based on B.F. Skinner's approach called applied behavior analysis, and this kind of design does have greater scientific control. So there is an independent variable, we've got a treatment level and a control level. That control level is the baseline, and then the treatment is whatever is believed that might help the person. So what we're doing in experimental designs that are based on applied behavior analysis is typically there is a client who is going to need some assistance in changing a behavior. And so initially, the behavior is observed so that we can establish a baseline, and then some kind of treatment is implemented, and we want to see, does that behavior change with the implementation of the treatment? So there are 3 different small n experimental designs that are used in clinical settings that I'd like you to be familiar with: the stable baseline, the multiple baseline, and the reversal. So the stable baseline, what happens here is that the participant is observed for a period of time before the treatment is introduced, and if there is this consistent baseline able to be established, then that is the feature that we need before introducing the treatment. So in this case, this was a woman suffering from Alzheimer's, and her recall for memories was very low. And so what they did was measure the percentage of words that she could recall. And you see that for the first 5 testing sessions, she could recall almost none of the words that she was being presented with. Where that dotted line occurs is where the treatment takes place. In this case, the treatment was an expanded rehearsal technique that was thought to be effective for improving her recallability. And you see that after that happens, her ability to recall words greatly improves. So we see the increase in the line after she has learned that technique. So we established a consistent baseline. We see the improvement after the treatment, and so that kind of pattern would suggest an effective treatment. The reversal design, this one is also called ABAB, where A refers to the baseline phase and B refers to the treatment phase. So just focus on the graph right now as I talk through what this is showing. So initially, it's a baseline phase, and so those first points over the first 10 days refer to the baseline. What this is measuring in this example is the frequency of responses. So let's say that there's a client who's engaged in some kind of undesirable behavior, and so we're going to establish what is the baseline of this behavior occurring, and then the treatment will be implemented. So in phase B, we've implemented a treatment. Perhaps it's some kind of reward given to the client for not engaging in the undesirable behavior. And we see in this case that that treatment is effective in reducing the frequency of responses. So you see that shift from A to B. During A, the responses were fairly frequent. During B, they dropped off quite a bit. Following that treatment phase, it's reversed. So we take away the treatment to see if the participant will go back to baseline. And in this case, that is what happens. The participant without the treatment goes back to baseline. And then we implement the treatment again. And again, we see the desired effect. So in this AB design, that's what we're hoping for, that anytime the treatment is implemented, we see the desired effect. However, sometimes that's not going to work out as we hope. So in this graph here, we see that there is that baseline established, the treatment is introduced, so the behavior drops off, but after the treatment has been taken away, we don't see a return to baseline. And so in this case, it's hard for us to figure out whether that treatment was effective or whether there was something else that might have changed the behavior. So if the behavior does not return to baseline, we can't conclude that the treatment was what caused the initial behavior change. There are other things that might have happened to create that initial change. For example, maybe there was a variable other than the treatment that caused the behavior to change. Maybe the treatment did promote the change, but there was some other variable, for example, positive attention, that caused the change to persist over time. Or it could be that some behaviors may be expected not to change after they've been improved. For example, if what we're doing is teaching a new skill to someone, then we certainly can't expect that to be unlearned after we have taught the person a new skill. So this AB design is really only going to work for certain cases, because there is also this ethical issue to it in that we may not want to remove a treatment if it has improved the quality of someone's life. If you think of a case where a client might engage in self-harm or harming others, if the treatment is effective at reducing those negative behaviors, is it really ethical to then take the treatment away and have that person engage in those harmful behaviors again? So there's this dilemma of really wanting to understand what causes the behavior to change, but also our goal of improving the human condition. And so in those cases where the AB design may not be suitable based on ethical issues, we can turn to a design called the multiple baselines design. So in this kind of design, the treatment is not removed. What happens is that we establish several baselines, and then the treatment is implemented into one baseline at a time so that we can see when the behaviors change. So this could be across different situations, could be across different behaviors, or across different individuals. For example, here is a case where it's across different behaviors in one individual. So this individual was engaged in some behaviors that were interfering with everyday life, touching face, touching hair, and grabbing objects. And if you look at the y-axis, you can see that it was happening to such a great frequency, which is why it was interfering with daily life. And so with the treatment that was being given, which was an overcorrection, you see that the treatment is implemented in the top one first. So the dotted line is when the treatment happens. When that treatment is implemented for touching the face, we see that the treatment declines. When it's implemented for touching the hair, after it's implemented, that behavioral frequency declines, and then grabbing the objects, only after the treatment is implemented for that one does the behavior decline. So you can see the pattern that the behavior only decreases in frequency after the treatment is implemented for that particular behavior. And then one more example for this one, it was 3 children with autism who had a fear of dogs, and so they were looking at how far away the child would stand from the dog, and then the treatment would be implemented, which was a reinforcement treatment. And so you see that the treatment is implemented at different days for each child, and only after the treatment is implemented do we then see that the child is getting closer to the dog. Some other examples of small n studies come from Piaget, who studied his own children. So his 3 children were his participants, but again, he did so with such good experimental control that we learned great information from those studies. Ebbinghaus studied memory, and his only participant was himself. And so that forgetting curve that we learned from him came from data that he collected doing an experiment just with himself. So these small n studies can contribute really great information.